Hello friends, in our last class we have started the congenital anomalies of the nose, right? This is the continuation of the congenital anomalies of the nose, right? I know last class is a little slower, but this class I'll try to make it faster, right? So in the congenital anomalies of the nose, in our last class we have dealt with bilateral choanal atresia. So the tests, so I would like to continue with the choanal atresia which I have left in the last class. So the first we have dealt with symptoms, types, and in the types we have dealt with unilateral and then bilateral. So now I would like to discuss the diagnosis of bilateral choanal atresia. So what is the diagnosis? So 1. Probing with catheter. So I think you have got what is probing with catheter. Here, if this is the nose, right? So you will be probing it with a catheter to see whether it is patent or not, whether it is free or not. If there is some obstruction, then that probe or catheter cannot pass through it. That is first test. And the other one is cold spatula test. So in cold spatula test, if you do this test, then there will be fogging developed on one side, right? So this can be done. All these tests we will deal in detail with in the next class. All the other tests. The next test which we can do is posterior rhinoscopy. Posterior rhinoscopy can be done. Okay, fine. Posterior rhinoscopy can be done, and it is useful if there is some complete. So in posterior rhinoscopy is mostly useful if and only if there is complete atresia, right? So it is useful. Complete atresia. Now the fourth test which can be done is air blow test. As the name says, we blow air into the nostrils to test the patency of the nostrils. So that is air blow test. And the fifth one is radio opaque test. Radio opaque dye test. A radio opaque dye is instilled into the nostrils. That is, dye is instilled. When the dye is instilled, and then where it is instilled into nostrils, as we know, and then X-ray is taken to detect whether they are choana or not. Or we can also do CT imaging, which is advanced. So we can do CT imaging. This shows type and thickness of atresia, right? What type of atresia is there and what is its type and thickness can be known by CT imaging. And as we said, radio opaque dye test. So the dye which can be used is methylene blue. Methylene blue dye can be used, or Indian ink can be used, right, to know the patency of the choana. Or we can also do diagnostic nasal endoscopy. Diagnostic nasal endoscopy can be done, right? All these are the tests which can be done to diagnose the nasal atresia, choanal atresia, right? First one, probing a catheter or core spatula test, posterior rhinoscopy, air blow test, instilling some dye, next CT imaging and diagnostic nasal endoscopy. And now what is the treatment which you give for this? So one is, here there is atresia. So what can you do? Transpalatal excision, right? You can excise it. The atresia or stenosis which is seen, that is the plug. Here there is some obstruction, right? So that obstruction can be excised, removed. The second one which you can do is transnasal endoscopic excision. Even here you are excising it, but here transpalatal excision is through palate. You will be going through soft palate, but here you will be going through nose, and it is endoscopic excision. It is not a full open surgery. It is excision through endoscopy, and then you do stunting, right? So what do you do in this? We'll deal it right now. So first you will excise it. We'll deal it in our next class, basically where we deal with all the surgeries, then we'll deal it. It's better. Right now just know what is done, and then you can do tracheostomy, right? Tracheostomy can be done. Then the second type of anomaly, third type of anomaly right now, which we are dealing with today, is bifid nose, right? Just a minute. So this is so called the bifid nose. If you see the image here, this is called as bifid nose. So how is it occurs? If you see, the etiological factors of bifid nose include failure of fusion. As we have fusion of what right now? As you can see there are, as I have said in my previous class, there are two processes, that is medial and lateral nasal processes, which fuse to form the present nose. So whenever there is failure of fusion of frontonasal processes, this leads to bifid nose, right? So these are the two examples of the bifid nose. What are the clinical features? So the clinical features, one is hypertelorism. What is hypertelorism? This is the distance between the two eyes. See, this is the distance between the two eyes is more. Hypertelorism is increased distance between two eyes, right? So that is hypertelorism, it is high. That is one clinical feature. The second one is cephalic anomaly, right? You can see some cephalic anomaly which is not normal. You can see a different anomaly, and there may be mental deficiency. This child may be mentally retarded, right? All these are the different clinical features which you see in bifid nose. Now coming to the treatment, what is the treatment? It's simple. It's surgical repair, right? You have to combine it. You have they are excluded, or you have to combine it and give some facial reconstruction. You have to do surgical repair with craniofacial reconstruction, right? You can do this craniofacial reconstruction. So this is one type, that is bifid nose. So here you have done with choanal atresia and then bifid nose. Now coming to the next one, which is, so now we are going to deal with nasal meningocele, right? So you can see both the diagrams of nasal meningocele, or it is also called as meningoencephalocele, right? So these are both the examples, or both the pictures of nasal meningoencephalocele. What does it happen basically here? Here, if you see, this is the brain and these are the meninges, right? There are two meninges, dura mater and pia mater, right? So these meninges and the glial tissue which is present, or the brain tissue to say, all this undergoes herniation to form nasal meningocele. So here what basically happens is, at the base of cranium, this occurs at the base of the cranium. One, what does it happen? Here there is herniation of glial tissue or brain tissue and the meninges, right? So here if you see, this is the part. Let me draw it with black, right? So this is the basic part. Here there is herniation of both brain and the meninges, leading to nasal meningocele, right? So where does the herniation occur? This herniation generally occurs in those areas where there is some persistent openings. Like, for example, this herniation may occur through foramen cecum, right? Or any other, it may occur through persistent foramen cecum, right? It may occur through persistent foramen cecum or any other natural opening, right? It may occur through persistent foramen cecum. So here what does it present? What are the presenting features? The presenting features of a person is basically, it may be a swelling, right? Or a mass like this, it may be a mass. So clinical features include, one, it may be a mass or swelling like this, presentation, or there may be nasal obstruction. If it is small, if the mass is really very small, then the patient may present first with nasal obstruction, right? So this meningocele is of 4 types basically. 1, it is of frontoethmoidal, right? It may be one type, frontoethmoidal, where the herniation occurs in the fronto and ethmoidal region, or it may be only ethmoidal region, or the herniation may occur in sphenoidal, or it may also occur in nasal region. So all these are the types of all the types of meningoencephalocele or nasal meningocele, right? So this is about the nasomeningocele. So as we said, the clinical features, basically there may be mass swelling, and due to this swelling there may be nasal obstruction, right? So what does this swelling or cyst has, or what do you see on anterior rhinoscopic examination? This is sign, right, which we see. We do anterior rhinoscopy, and in anterior rhinoscopy we find soft, bluish, cystic, compressible, and translucent swelling. right? You see soft, bluish, cystic, compressible and translucent swelling. So how does it look like? So let's take, this is low, so this is around. So there may be bluish basically, and it is cystic, that is, it is basically of cysts. Compressible translucent swelling is seen just like this, right? So this swelling increases in size on cuffing, that is, positive cuff impulse is seen. Once we cuff, there is increase in size, that is, increase size of swelling. If the patient cuffs, there is increased size of swelling, right? So this is seen in anterior rhinoscopy. So this is a swelling on anterior rhinoscopy. If you see, you can see bluish, cystic, compressible, translucent swelling, right? So now, what are the investigations which you would order the patient to do, or which you would suggest the patient to do? One is CT scan or MRI. You can do any one of it, of skull basically, and you can do both coronal and axial roots, and you can also ask them to get nasal biopsy done, nasal endoscopy done. And what is the contraindication? Biopsy should never be done. You should not do biopsy, remember that. Never and never you should do biopsy. Now the treatment of it. The major treatment of this is transnasal endoscopic excision. Transnasal endoscopic excision can be done here, right? So here we have this is the treatment of nasal meningocele, right? So this is about nasal meningocele, where there is herniation of brain or glial meninges or glial tissue into the nose or nasal cavity, right? So this is about nasal meningocele, the types and the investigations which you ordered and the treatment of it. And so first you do transnasal endoscopic excision, which is a treatment of choice. So what does you do? What is excision? Removal of the brain tissue. So you remove the brain tissue, the whole brain tissue which has come into the nasal cavity, one, and then you have to seal the defect, or else it would be recurring. So first you do excision, and then you would seal the defect with bone or skin graft, right? You can do bone, or you can take skin graft, and you can seal the defect, right? If this is extensive, then you can go to craniotomy, right? So this is about nasal meningocele. So now the next major thing which you are going to learn, now is glioma, right? Glioma. So here let us first deal with glioma. So here, this glioma is a congenital malformation. As we are dealing with all these cases which are congenital malformations, even this is a congenital malformation, which is an isolated mass, that is brain tissue. which presents as a nasal mass. If you see, this is a baby with glioma, but here if you see, this is not a mass which is derived from the nasal tissue. This is the mass which is derived from the brain tissue, right? Glial tissue. So what does this mean? Here there is a heterotropic brain tissue. Heterotropic brain tissue. This brain tissue would presents has nasal mass. The thing is, if a patient with this, or if this boy has come to you in your clinic, you feel that it is some nasal mass which is protruding out. But in reality, if you do a biopsy or some invasive techniques, then you will know that it is heterotropic brain tissue, right? But why do you think brain tissue comes here? As we have already seen in encephalocele, there is herniation, right? Even here, first there is herniation of brain tissue, just as encephalocele. This herniation leads to this herniation, basically this occurs in intrauterine life, right? This occurs in intrauterine life, that too through foramen cecum, which is a natural opening, right? This occurs, this herniation of brain tissue occurs in intrauterine life itself, like this, right? There is herniation of brain tissue which occurs, which is just same like encephalocele, which occurs, but here it occurs in intrauterine life. And once this herniation of brain tissue has occurred, then the child passes from intrauterine life to, he increases from early intrauterine life to late intrauterine life. And in the late intrauterine life, if you see, that is late IUF, what happens is there is fusion of bones occurs, right? Most of the cranial bones are fused in the late intrauterine life. So fusion of cranial bones occurs in late intrauterine life. This fusion basically leads to detachment of stalk. So if you see, there is detachment of stalk resulting in glioma, which you can see here. Right here there is no stalk and there is fusion of bone which has occurred, and this has led to glioma right now. So what are the clinical features? The major clinical features here include 1. Nasal obstruction, right? Because of this tissue, this growing mass may lead to nasal obstruction. And you can see, just like in encephalocele, even here you can see bluish nasal mass, and this is non-compressible, right? Even this is non-compressible. See the difference between encephalocele and the glioma. If you see, it is non-compressible mass, but encephalocele or meningoencephalocele, it is a compressible mass. So this is the major difference between glioma and the encephalocele, right? So now next, this here Furstenberg test is negative. And you should know what is Furstenberg test first before saying that it is negative. As I have said, the swelling increases in size when one coughs, right? That occurs in meningoencephalocele. That test is called as Furstenberg test. That is increasing in size of swelling on coughing. Right? So this is Furstenberg test. It is negative in glioma and positive in meningoencephalocele. What are the investigations which you can ask one to do? What investigations do you feel are better for this case? These are same. has meningocele. You should do CT scan, MRI and other investigations same as meningocele. And what is the treatment? The major treatment is excision. But how do you excise it? This excision can be done by endoscopy, right? So this can be done in glioma. Right here there is herniation of the brain tissue in the intrauterine life, and this may lead to fusion of cranial bones. When occurred in the late intrauterine life, this may lead to detachment of stalk, which leads to the formation of glioma. Right? So these are the clinical features, diagnosis and treatment of glioma. So now coming to the next major thing, which is dermoid. So now let us deal with dermoid. So these are the different pictures of dermoid cyst. So this is an ectodermal cyst. Right? And it has an epithelial lining is seen, plus dermal structure. There will be an epithelial lining with dermal structure. So here what are the clinical features? So you see this is a dermoid cyst, right? And this dermoid cyst will have, mostly it will have an opening to outside like this, right? Like this, there is an opening to outside. So this is called as punctum. If you see, you have here an opening to outside. This here you will have opening to outside. Here you have opening to outside. So this is the difference between meningioma, encephalocele or meningoencephalocele or glioma, which we have seen. Even these two are the swellings of the nose, but there is no external opening for them. But here you can see, in most of the cases there is external opening. So this is a fluctuating cystic swelling, right? It is a fluctuating cystic swelling the person comes with, and this swelling may result in nasal obstruction, right? And this mass is compressible, just like meningoencephalocele. It is compressible and non-expansible, right? And if you see excuse me, Furstenberg test, which is seeing impulse on coughing, that is whether there is increase in size on coughing or not, to see that test is negative in case of dermoid cyst. It is only positive in case of meningoencephalocele. So what is the treatment of this dermoid? It's simple, excision of the cyst, right? We have to excise it. So the last and final cyst or congenital swelling which we are dealing today is congenital cyst or fistula. This congenital cyst or fistula is not a different entity from dermoid, right? This is a continuation, this congenital fistula is a continuation of the dermoid cyst, right? So here if you see, why does this congenital cyst or fistula occurs? This occurs because if there is failure of separation of ectoderm from dura, if there is failure of separation of ectoderm from dura, there is a dura mater and from over that there is ectoderm. If there is failure of separation of this ectoderm from dura during development, this leads to, as ectoderm isn't separated, so this ectoderm is nothing but the skin. So this skin is entrapped in the prenasal space, that is ectoderm or the skin, future skin or the skin, it is entrapped in prenasal space. This same as dermoid, right? Even this pathogenesis you can even write for the dermoid cyst, right? So this ectoderm is entrapped in the prenasal space. This results in dermoid cyst, right? If this dermoid cyst, if this is opens outside, opens on skin surface, this opening occurs through fistula, which is congenital. So this is called as congenital fistula. So this is the pathogenesis of both dermoid cyst and the congenital fistula. It is mainly due to the failure of separation of ectoderm from the dura. What are the clinical features? The major clinical features which the patient presents to you is there is a sinus or fistula which opens outside, that is there is a small opening which is discharging. The patient complains of some discharges which are released outside, and the patient, if you see the investigations, the major investigation is CT scan or fistulogram can be done. And what is the treatment? The treatment is complete excision, right? All these are the congenital diseases of the nose, right? So now here we have dealt with many diseases of the nose like penile atresia, right? And then we have dealt with a meningous bifid nose, then meningoencephalocele, glioma, dermoid cyst and congenital cyst and fistula. But here what is the most important thing which you have to see is the differences between nasal meningocele, right? Not dermoid, glioma first. Let's go in the same order to not to confuse ourselves, and then dermoid cyst, right? What are the differences between them? Because all these are swellings which look alike. So the first difference is all these are masses. So this is bluish mass, even this is bluish, right? So here if you see, this is compressible, and Frustenberg test it is positive, that is it moves on cuffing, right? So these are what which is important and which are the major differences. And if you see the glioma, one, it is even bluish and it is non-compressible. There is no compressibility, and this Frustenberg test is negative. And if you see the dermoid cyst, when this is a cystic swelling and this is compressible, and Frustenberg test is negative, and even this is fluctuating swelling, right? All these are the major differences which you have to remember, because one may confuse by not knowing them. So this is the end of the chapter congenital anomalies of nose and the paranasal sinuses. Okay, then thank you for listening my lectures, and bye.